Hello and welcome to the Dissect and Connect podcast. I'm your host, Mike Wade. This is the podcast where we explore population health issues impacting your community. Dissect and Connect is a service of New River Valley Community Services and the Montgomery County Prevention Partners. Aaron Housh is Chief Executive Officer of Good Samaritan Hospice, a position he's held since November of 2018. Good Sam, as it's often referred to, is the only nonprofit community-based hospice serving both the Roanoke and New River Valley areas of Virginia. A native of Texas, Aaron earned a bachelor's degree in political science from Berea College in Kentucky. After graduation, he accepted a position with a local nonprofit hospice organization where he says he found not only a job, but his passion. His entire career has been devoted to end-of-life care, where he has gained extensive experience in hospice leadership and operations, working for organizations in both West Virginia and more recently in North Carolina. So Aaron, welcome to the Dissect and Connect podcast.
Thank you so much. Very happy to be here.
Yeah, we're excited to have you on. So most of us have heard of hospice care, but for those who aren't necessarily familiar with that concept, can you tell us what that really means?
Yeah, absolutely. A lot of people are really scared of the word hospice. I mean, that's what we intersect with across the communities, that people hear the word hospice and they think of course, death and dying. And sometimes they think of really what is the end of someone's life, the very end of someone's life. And hospice is absolutely here for that time and here to support patients and families during that time. But it's a much bigger concept and philosophy than that. The hospice philosophy is really to care for people that are really advanced in their illness and approaching the end stage of life. In order to be eligible for hospice, we work with physicians to get prognosis, and for the most part, that prognosis is really 6 months or left if the disease takes its normal course. But we care for patients all along that spectrum. You know, we have patients for sometimes as short as a few minutes or hours. We recently, at Good Samaritan Hospice, had a patient that had been on our service for almost 6 years.
Wow.
So it's really a sort of a wide variety. Of course, someone has to be end stage in their disease and really needing the support of end stage care and advanced illness care. But we really care for people all along that spectrum. You know, hospice is also a holistic approach to care. So although we care for patients in the physical part of their illness, we're also providing psychosocial support and spiritual support. We have a whole team of care that takes care of patients as they approach what really ultimately is life's end. But they, you know, with our goal really being focused on helping those people be as comfortable as possible, but also as much focused on the life that they have and how we can help and encourage them and help them live that life to the best of their ability. Most people that enter into hospice, of course, are on some level choosing non-curative care, right? And so oftentimes that's termed as comfort care. So we are there to help keep patients comfortable in the setting that they want to be in. Most people would tell you they don't want to spend the end of their life or the last 6 months of their life in and out of the hospital. They want to spend that at home with the people that they want to be around. And so our job is to help that and help facilitate that as much as we possibly can, so people can be where they want to be with the people that they want to be and as comfortable as they can in those moments.
So what are the differences between hospice care and palliative care, or are there differences between those two?
Oh, that's a great question. So palliative care, it's sort of strange. By definition, hospice is a form of palliative care. But across the nation and across our communities, there really have sort of grown two sort of separate programs around hospice and palliative care. So hospice is really focused on when someone has elected that they really just want comfort care. They no longer want curative care. That's really when hospice comes in. And hospice is very different in the sense that when someone elects hospice and comes on our service, we really start managing all of their care from that point forward. we are really taking care of every part of the medical component of care from the point that they elect to the time of their discharge. Palliative care is very different in nature. Palliative care is a specialty inside hospice or inside medical care that is focused on comfort. But oftentimes what we see across the nation now is that palliative care is a program that is really specialized care in nature that's sort of consultative. So, for example, here at Good Samaritan, we just kicked off on July 15th or the 1st of August, our own home-based palliative care program. So we actually have a separate program that's called Palliative Care. It's called Good Samaritan Palliative Care. We see patients in their home, but that is ran by a nurse practitioner, and that nurse practitioner really serves as a medical specialty. So she's, for a lack of better term, she's sort of like a traveling clinic, specialty clinic, just like a cardiologist or a neurologist that your primary care would sort of send you to say, hey, you're having some issues with pain and symptoms at home. I need some help with that on the comfort side of that, and that we would come in and help facilitate that. We also have social workers, licensed clinical social workers and chaplains that help assist in that program. But it's really a medical specialty. We're not taking over, for example, in that program, all aspects of care, where in hospice, we're covering medications and durable medical equipment and almost anything that occurs along the spectrum of your healthcare needs. In palliative care, we're just going in as a medical specialty to often work with your primary care physician to say, hey, this person's really struggling, for example, maybe with shortness of breath or with pain. And our recommendations to help keep them comfortable are this. Occasionally, we may even prescribe those medications and see that patient more regularly in the home setting. But it's a very different kind of program than hospice in that it's a consulting program, and hospice is much more comprehensive in its overall scope of care. And sometimes it's confusing because you may go to a different region, for example, across the country, and palliative care may look very different. Even locally here, our hospitals treat that differently. Carilion Health System actually has sort of a palliative care program where they may have a palliative care nurse or even palliative care physicians in the hospital that are doing consults to help people with goals of care, with symptom management and those kind of things. And whereas another hospital here may not have a palliative care program at all and much more depend on someone like Good Samaritan to help with that. And so there's a lot of confusion in what does palliative care mean? Because oftentimes when people hear the word comfort care, they sort of maybe think that those are interchangeable when the reality is, as far as how programs operate, they're really two separate kind of programs. Let me just say one other thing about palliative care.
Sure.
So palliative care, people can be getting curative care and also palliative care. So they may, for example, someone may have a cancer diagnosis and be getting chemotherapy or radiation. They're not yet ready for hospice. They want to try, they want to continue with some therapy, but they're having some major issues, symptom management issues from that treatment. So we could go in concurrently with that, in partner with the oncologist to help make sure they're staying comfortable and their symptoms are managed at home previous to a hospice admission. So it's a little bit different. It's a little bit up the care continuum some. I always say that for the most part, I think that most places will define you can be in palliative care programs once you get an advanced illness at any place, any age. But a lot of times the prognosis is probably potentially 24 months or less, or maybe 18 months or less, and maybe not 6 months or less.
Good to know. I kind of just jumped right into the questions and didn't really give you a chance to do kind of the elevator pitch about Good Samaritan Hospice. So can you talk a little bit more about specifically your organization, its mission, and some of the key programs that you offer?
Yeah, absolutely. Good Samaritan Hospice is the only community-based nonprofit hospice that is serving the Roanoke and New River Valleys. We were established in 1992. We were founded by a couple of people that just literally community members. One was a nurse, and that just came together and said, we really believe that this area needs a community-based nonprofit hospice that's focused not just on hospice care, but also on supporting the community with issues related to the end of life. Maybe that's bereavement or other services. And so in 1992, those two individuals really left their jobs and started Good Sam in January of 1992 with no promise of even a paycheck. My understanding is that they did not receive their first paycheck for about 6 months.
Wow.
And so for the first 6 months, they were really volunteers. They just really felt strongly that this area needed a community-based nonprofit hospice, and they made some sacrifices to make that happen. So since 1992, Good Sam has been the community-based nonprofit hospice provider in this area. We, of course, offer a range of services inside our hospice program. I mean, our hospice program is by far what our focus of our care and programs are. But as I mentioned earlier, hospice is a holistic approach to care. But inside of that, we also are focused on outreach to the community, helping the community with the needs around end-of-life care, but also grief and bereavement. So we offer programs for our patients and their families inside grief and bereavement, but also to the community at large. And as I mentioned just recently, we started a new program, which is Palliative Care, serving the community for patients that aren't yet ready for hospice, but are needing help navigate all the many complexities as they are managing an advanced illness.
You've been on the job for about 2 years, close to it. What's the scope of your services? I mean, give us an idea of like numbers or quantities of individuals and families that you work with in a given year, per se.
I'll start maybe just with a given day.
Okay.
A given day for us, we have probably about 100, on average, about 185 patients under our care a day. Over the course of a year, we're probably, I would say, between 900 and 1,000 patients that we touch in a given year inside of our hospice programs. But on a given day, we have between 185 and 200 patients that are receiving our hospice care service.
And that's across both the Roanoke and the River Valleys, correct?
That is correct.
Okay.
That's Roanoke, New River Valley, and the Smith Mountain Lake area. So okay. we sort of really cover about 9 counties that we serve. And so across those 9 counties, we're serving about 185 to 200 patients a day. And that really varies, based upon location. Out of our office here in the New River Valley, over the course of the last year, we probably averaged about 63 patients per day out of this office, something like that.
Okay.
And we really serve out of our New River Valley office. We serve Montgomery County, but we also serve Johns County, Floyd County, Pulaski County.
Okay, very good. So we talked about this just a little bit before we started recording, Aaron, but I wanted to get a better understanding of how Good Sam has been impacted by the COVID-19 pandemic the last 6 months.
Well, I mean, I think that I can answer this somewhat globally, as everybody else would probably agree. It's been an interesting time in healthcare, interesting time in our nation, and I know the impacts across the board in our economy and all those things. And, Good Sam, from the very beginning, we made a commitment as these things started to change, as COVID started to outbreak across our nation, that we would do everything possible that we could to continue all services to our patients during that time. And so we've had to make a lot of adjustments. And of course, care looks a little different than it did previous to. And I say looks, and I can sort of say that in quotes on some level, because I actually mean that. One of the big changes to our care has been the addition of standardized PPE for our staff. So that's protective equipment that our staff are using on a daily basis. So all of our staff wear eye protection, a mask, and gloves on every visit. And that's pretty standard for every time we touch a patient. Some of the facilities that we serve, and we partner with skilled nursing facilities, assisted living facilities, they actually have different protocols and standards for us And so we adjust to those. So, for example, we have some of our facilities who require full PPE, so we wear a gown, hair covering, shoe coverings, everything. So that's been a really big change for us. I mean, we are not normally those that wear a lot of PPE in the care that we provide,
Right.
but now it's very standard. So that's been a big thing. One of the things that we have seen is, some of our partners in our facilities have sort of at different times, based upon the outbreaks, have had to go on lockdown and not necessarily let our staff into their facilities, or we've had families very concerned about staff coming into their homes just because of the virus and the fear of the virus. So some of our care has changed even inside of that. We quickly implemented telemedicine visits that had not been really standard for us previous to that. So we got a new platform. We actually use a program called DoxyMe that we can actually, our clinicians register with. They send a link to family members or patients or maybe staff members at facilities that they can link directly to our clinicians. That's our nurses, social workers, chaplains, physicians, nurse practitioners. Everyone that's on our team can visit our patients via telemedicine now and via televisits. Previous to COVID, that was just not something standard to us. And in fact, I actually think that we always went away from it. It wasn't something we wanted to do because we want to see our patients, we want to touch our patients, and we want to be able to make those hands-on assessments. So we quickly adapted to some of those things. We certainly, for a period of time, really were trying to prepare for what does an outbreak of COVID in our area look like for end of life, right?
Right.
Because we are an end of life resource and want to be able to respond to those patients and families that have end of life issues related to COVID. So we did a lot of work on how will we care for patients that are COVID positive and maybe actively dying or at the end of their life due to COVID. We haven't had a ton of intersection with those patients. I think a lot of those patients have been in the hospital during the end of their life, and the hospitals had their own plans for that. But we have had patients that have been COVID positive, and we quickly sort of developed a COVID team. And so we had a COVID team that would sort of serve those patients in all of the counties that we serve. So we had a nurse, a physician, and other members of that team that could serve the patient, and those patients would be devoted to the COVID patients, meaning they wouldn't go see a COVID patient and then go see other patients.
Right.
And so we did have a team that we devoted to those patients, and were able to touch those patients and reach out and not only admit them to hospice, but provide care to them. But those haven't been as in great of numbers that you might think that they would be, just given, because a lot of the patients, when they are very ill with COVID, are isolated to the hospital setting.
Right.
And of course, the hospitals were very much limiting the kind of resources that they were having in the building, just to sort of mitigate the risk of exposure in general.
Definitely a different time for everybody.
Yeah, we're still adjusting. As I mentioned before we got started, it's just almost a continuous sort of reading of the news and understanding the positivity rates and how we need to respond. Just recently, there was some new rules that came out from Medicare to our long-term care facilities or skilled nursing facilities that required a different kind of testing for not only their staff and residents, but also the partners, and we're partners. And so we've had to really figure out how to adjust quickly to those kind of things. So if you have to test your staff regularly, how are you going to be able to get that done? And sort of overcoming those obstacles. I think when we knew we were going to have to start testing the staff going into facilities regularly, the thought was we could partner with someone locally that we could send our staff and get them tested. And it's not necessarily an easy process to get tested. It's certainly not a quick process all of the time. The hospitals and occupational medicine places aren't really offering those kind of tests. So we've had to figure out ways to do that on some level internally and just adjust as those things come out. But any of our staff that are now visiting facilities are actually getting COVID tested twice a week. And so that's been a big adjustment for
Yeah.
us, figuring out how to get those things in place. Because what we don't want is for, a virus or the COVID virus to be a barrier to people of getting good end of life care. People still, and based being a mission based organization, our mission drives what we do. And so often, no matter what that is, it is our job as Good Samaritan Hospice and as a mission based hospice to make sure that there are not barriers to fulfilling our mission. And so it's been very interesting to identify those barriers and try to figure out how to get around those barriers, but also respecting people's privacy, but also allowing people to help control. When you have a family that is fearful of the virus and doesn't want you into their home, and the virus is sort of the barrier to care, we have to figure out how to still touch those people and serve those people. Another thing that we're working pretty diligently on, and on also expanding that currently, is one of the things that we've seen, particularly across the state and some of our partner places, is that when people live in facilities and facilities are on lockdown and their family can't get there, it becomes very difficult for the patients that live in there to not feel isolated and struggle with a lot of issues. And so when we're able to get into facilities and touch those patients, we've been really working to empower our staff to be able to connect that patient to their family who may not be able to see them during that time. So all of our staff, recently we've upgraded them to iPads that are connected to data so that they can connect more readily to families. But also during their visits, maybe we're getting into a facility to see a patient and their family doesn't live close or they're not able to visit currently, that we're able to make some of those, those video calls to their family so that they can connect to each other and we can help facilitate that. So it's just sort of a different world, and I think that we're doing the best that we can, but there certainly has been obstacles to care that we've had to overcome, and in continuing to have to overcome. I think that as we move forward, based upon the Virginia, Department of Health and what's going on at the federal level, we'll have to continue to adjust to their recommendations.
Well, I admire the level of innovation and creativity that you are obviously using to make sure that you're getting in touch with people and getting connected with them and making sure they have the care that they need. I think that's incredibly admirable of you and your team. So kudos to you for that.
Well, thank you so much. I mean, that is one of the wonderful benefits about being a part of an organization like Good Sam. We have wonderful people, and our people really care about our mission. And I think that that's what makes us different. I just say, as a hospice in general, is that we are a mission-driven organization that's really owned by the community. Our governing body is our members of this community right here. And I think that's also just what makes us different as an organization, that our response is hopefully innovative, but it's also mission driven. But more importantly, the people here are wonderful people that are really driven to make sure that we are providing and meeting the needs of this community.
That's actually a really great segue into the next note that I had made about questions or things to talk about. I have unfortunately learned from personal experience that not all hospice providers are created equal. Over 20 years ago, when I lost my mother, had an outstanding, just incredible experience with the hospice providers. Last fall, when I lost my father-in-law, it was a different story. In fact, I'm still somewhat dumbfounded by the contrast between those two experiences. And so for folks who are in that situation where they're seeking care from a hospice provider, what should they be looking for? What are the things that they should be looking for in a provider?
I started my career in community-based nonprofit hospice 17 years ago, really with not the intention on staying in hospice. I was really took the job almost as a placeholder while my wife finished school. I mean, that was really the thought at the time. And I really fell in love with the mission of community-based hospice. Not only because of the care that we're providing, but also our focus in the community and making sure that our community is taken care of. And I think that there's, hospice I've been in hospice, let's say 18 years or starting my 18th year. When I started in hospice that many years ago, the hospice industry looked very different. And I say that because about 80% of hospices, I think, across the nation at that time were community-based nonprofits. We now make up, I think, about 30%.
Wow.
So there's been a very big change in the industry across the nation. And while I think that there are some really good things about that, I mean, there's pros and cons to that. There's been great growth in the hospice industry across the nation. I think more people are getting quality end-of-life care and access to quality end-of-life care than ever before. There are some definite thoughts that maybe not all hospices are created equal. And I think when you see one hospice, you've seen one hospice.
Right.
I mean, we all have the core sort of basis of how we're set up. Medicare sort of tells us how to be set up in order to bill. But I think that one of the things that you'll see that I think is different in community-based hospice, nonprofit hospice, is we, on some level, what we're trying to do day to day and what we do as we grow. For example, like I said, we are owned by this community. So the input into the kind of care and services that we are offering are from people that know us and have experienced our care. I think one thing that really sets us apart is we also have a full-time medical director that works at our that is exclusive to our facility, that's board certified in hospice and palliative medicine, and is actually out in our community seeing our patients and family. We have nurse practitioners on staff that are in the community and they're seeing our patients face to face. But I think our investment at the end of the day, if we are always looking at where are the holes and the things that fall short in our community, and if we have extra resources, if we can make those kind of things work, we're going to reinvest that right here back into the community. And that's why we started our palliative care program. Not to get really off into this topic, but one of the things that we're thinking about now and as we're looking sort of into the future and our strategic plan is one of the great needs that I think that we see in the Roanoke and the River Valley, all the areas that we serve, is the need for inpatient hospice care, which there's not a real resource for inpatient hospice care in this area. And there's very few resources for that across the state of Virginia. Previous to coming here, I worked in the state of North Carolina, and previous to that, I was in West Virginia and Kentucky. All of those do hospice a little bit different. They're all considered what they call certificate of need states. So there's not as many hospices across the state, but all of those states have a lot of hospice inpatient facilities. And a lot of people might have heard those as hospice houses. And so one of our strategic plans is that we have seen our patients who sometimes need a higher level of care that can be provided at home, but they need hospice care. They don't necessarily need hospital inpatient care that's much more aggressive in nature, right? They need sort of that gentle touch of hospice and a focus that's a little bit different in philosophy. So we're really thinking about the future and how we as an organization can facilitate those kind of things for the community and offer this level of care. Maybe it's a hospice house, maybe it's partnering with an organization where we can have beds where we can provide that higher level of care. But I think that's really that what makes community-based nonprofit different is our focus is on this community. And when we do have extra resources, when we do see needs from our patients and families, our goal is to react to that, to create those other levels of care that people really need. And the truth is, the areas that we serve could really benefit from a higher level of hospice care that can just be provided in a patient's home. Just last week, I was talking to our director of nursing. She came to me and she said, we have 2 patients right now that need a hospice house. She said they need to go somewhere where that, number one, that they can get sort of around-the-clock symptom management. But there's often times where those families also need a break. And they need that level of hospice care in sort of a different setting. And so we're really focused on looking at our community how can we respond and how can we meet the needs? And I think that's one thing that makes Good Sam and community-based hospice very different.
Well, I'm incredibly excited to hear that you all are thinking that way because, again, going back to my personal experience, that would have been an incredible asset to have during my father-in-law's illness. And I'm sure that's the case with a lot of families. So that's really encouraging to hear.
It's not only encouraging to hear. I also think that on some level, just with the people that I've talked to since I've been in this area, I really think that people in this area really want to see it happen, and I think are committed to wanting to see it happen. And I really do think that we will see some potential progress over the next, hopefully 15 to 18 months, where we really start. Those kind of things are complicated because hospice houses are also, I won't say they're difficult to run because they're not, but they're not inexpensive to run.
Sure.
And so those, in order for us to go there, our board would really have to commit to a capital campaign and really looking at some fundraising efforts. But I think this community would really support such an effort.
I tend to agree with you. I think so.
Yeah.
Death and matters related to end of life are obviously not things that most of us like to think about, but the reality is it's something that we all have to come to terms with at some point. What's the key to helping folks who find themselves in that situation with a loved one?
I always think that the key to that is on some level just honesty.
Mm-hmm.
And that's not only from patient to family, family to patient. That's also from healthcare provider to patient. And, so many times I think that there's this fear of talking about death and dying. It's really hard to face your own mortality. And it's death and dying is difficult. I'm not inside a hospice setting, but I lost my dad in December unexpectedly.
I'm
and
sorry.
I can say from someone who has been around this my whole life, it has knocked me off my feet.
Mm.
And it's a difficult thing to process. It's a difficult thing to deal with. And so I think because it's so difficult to deal with, we often avoid it.
Right.
And we often, and what we see in hospice is that for the most part, most all of our patients could have benefited from hospice months earlier. But what we see is that people oftentimes their healthcare providers don't always have those difficult conversations. Families avoid having those difficult conversations. And then when they need hospice, they're often in a crisis.
Right.
Or when they get referred to hospice, it's often to help get them out of the crisis that they're in. And I always just encourage people to be really honest with each other. As you're going through advanced illness and progressive illness, I think it's okay to have conversations about what if this treatment doesn't work? What is our next step? I think it's very important to have those conversations with your doctors and your providers to say, I understand that we're going down this path, but will you be honest with me when you think this isn't going to work anymore? Because the truth is, most of the time when it comes to progressive illness or it comes to life-limiting illness, the outcome is the same, no matter what.
Right.
At some point, are you going to be in a place where you are sort of more in the comfort of your home, spending time with your family? Are you going to, choose to spend that time sort of in and out of the hospital and doctor's offices and traveling from here to there? Most of the time, the outcome when it comes to advanced illness is relatively the same.
Right.
And so just being honest with each other and having those conversations about what you want. We have a lot of promotion of wanting our communities to really talk about advanced care planning and having conversations with your family about what you want and don't want when you can no longer make your decisions.
Mm-hmm.
And we cross paths with a lot of those difficult situations where people had not had those conversations, and they're difficult conversations to have, but they're so important. It's so important to be honest with each other. And sometimes, families push patients to seek treatment well past the time that it's still helping them. And patients don't want to be honest, but sometimes that happens with opposite too.
Yep.
But I think it's just important to be honest about what your goals are, what you want, how you want to live. And when hospice intersects with that and can help you to live the best that you can, sort of in the comfort of your home and in that place. But I think honesty to me is just what came to mind when you asked that question.
No, and I think that's sage advice that you gave. So that's I think exactly what people need to hear. So thank you for that. In addition to some of what we've already talked about, I'm wondering if there are maybe one or two key misconceptions that people have about hospice care.
Oh, yeah. One of the things that I do believe as an industry, I hate to call us an industry, but as a growth of a movement across this country, hospice has made great pride or strides in the misconceptions about who we are and what we do. I think one of the biggest misconceptions is that hospice is really just about giving up.
Right.
If I get hospice, it's about giving up.
Right.
I actually find some of our care and the care that we provide, particularly in the pain and symptom management, to be some of the most aggressive care. If it's good, if we're doing the right job, very aggressive care in helping to manage people and making sure that they're comfortable. But I think that people often say, "Oh, it's just about giving up."
Right.
If I go to hospice, I'm giving up. And I really think it's really about redefining hope, right? It's about redefining what that hope may be. And you may not be hoping to live to your child, maybe your child's graduation in 10 years. But maybe we can help redefine that maybe your new goal is that, sometime in the next few months, we're going to go fishing and we're going to spend the day together.
Right.
And what can we do to help facilitate that? But I think that that's one misconception. I think also people really a major misconception is hospice is just about the end. It's just about that last, 24 to 48 hours when someone really is at the end of their life.
Right.
Hospice, we do our best work when we've actually been able to build a relationship with the patient and family over the course of months. If we have 6 months with the family to help prepare them, to help give them valuable time, to help maneuver that sort of journey together, that's when I think that we actually have the most impact into our patient and family life. I also think another misconception, I still hear this occasionally, which was sort of strange, is there's still a misconception that hospice is there for cancer patients. And it's very interesting to me that I hear that in the community, that they think the majority of patients that we care for are cancer patients. And it's interesting, only about 35% of the patients that we care for have cancer.
Really?
And nationwide, that's now in the high 20%. So we care for patients with, end-stage heart disease, lung disease, Alzheimer's, most every disease as it progresses can be considered a life-limiting illness.
Sure.
And so we care for patients, with all kinds of diagnoses, not just cancer. But that is often a misconception that people still think that the majority of patients that we have cancer, and that's really not the case anymore.
I have to admit, I would have assumed the same thing was true, that the majority of people that you work with are in some form of cancer diagnosis. But that's interesting to hear.
Yeah, I think for us, it's in the high 30%.
Okay.
Somewhere in there. But that's still not the majority of the patients that we care.
Yeah, interesting. Curious. This must be emotionally very taxing on your staff to routinely, constantly deal with the matter of death and end of life. How do you support them through that? What kind of supports do you provide your staff?
Well, that is a great question and something that is very difficult. Death and dying and caring for people that are really declining in general, right?
Mm-hmm.
These are patients that are normally getting better over the course of time. It's just a very difficult, and then losing patients on a consistent basis, very difficult. I think more than anything, having great hospice is about having the right people. And I think we do a great job at Good Sam of making sure that we get the right people and we recruit the right people. This is not for everyone. And there are some wonderful people that can't do this work.
Sure.
because it's just too taxing on their heart and on their
Yeah.
emotions, and they have difficulty. But internally, we really try to support our staff as much as we can. A lot of that, we have some internal sort of bereavement programs that we do. We do internal memorial services. We often, our teams that are going, often self-identify when they've had really difficult deaths as well. And when we have those people, we try to identify them, help them, give them resources. Of course, we have external resources for them if they're really struggling with that grief and loss. But we have, one of the great things about our team is that we have licensed professionals that work on our teams, counselors and chaplains, that are really in tune, as well as bereavement counselors, to our staff, and focus to make sure our staff are dealing with that and able to do that. I still think it's hard. I think anytime you're caring for patients that you lose a lot of those patients over time, and you get attached to families and you lose those families and those patients, it's just really difficult. So we do the best job that we can to have internal sort of bereavement and focus. I know just not long ago, I had our director of nursing come and say, we've had a lot of death lately related to one specific nurses that we have, and we think that she's really struggling, and we think we need to give her some time off, and really just some time to really almost bereavement time for herself, to refocus on herself and give her some support, maybe adjust her caseloads, and really look. So we really try internally to support our staff in that way, because this is not easy work. It's not easy for our staff to, on some level, have losses every day, because that's sort of what they're doing on some level, and to help people manage that loss. So they are also going in with families who are having that loss and having to support them through that without almost getting that reciprocal support, right? Because we're there for them. And so just having sort of formalized internal bereavement, but also being pretty attuned to how our staff is feeling and the kind of loss that they're having, is really important.
Definitely heroes, for sure.
Yeah,
to take that on.
Absolutely.
Yeah.
Our staff are that.
Yeah. Hey, I don't want to keep you too much longer, but Good Sam's been making a push recently to get some volunteers recruited. Mm-hmm. For folks who are interested in potentially becoming a volunteer, what might that look like?
So, hospice volunteering can really look all kinds of different ways. So we're always trying to recruit volunteers who want to participate in patient care. And so what that really looks like, it can look very different. We have volunteers that support our patients at facilities, oftentimes, and in the homes. Oftentimes that's just companionship. It's just sort of stopping in to check in on people, spending a little time with them, often listening to their stories. Maybe it's a patient and listening to their life story. Maybe it's a family member that just needs to talk. I mean, these people are going through very difficult times of their life and processing grief. So we're always recruiting patient care volunteers. Sometimes that's sitting with the patient to give the family members a break. Maybe it's stopping by once a week for an hour so that family member can run to the grocery store. Caregiving is a taxing job.
Yes, it is.
When you're the primary caregiver, I think it's one of the most difficult jobs in the world, because it's nonstop.
Absolutely.
24 hours a day, 7 days a week. So our volunteers help sort of with that. I call it respite, but they're just stopping by, maybe allowing someone to take a walk around the block, maybe to run errands, to pick up medication, to go to a doctor's appointment for themselves. Sometimes, but we also have volunteers that aren't comfortable going into the patient settings, and so we have tasks that they can help with around the office. We have volunteers that do some computer work for us, and filing and answering the telephones, making blankets for our veteran patients. We have volunteers that come in and make blankets that we present to our patients who are veterans. So volunteering really is, a lot of times, is based upon what is most important to that volunteer who wants to come here. And if they have a desire to be here and want to support, we can probably find a place for them. But we have a couple of people that work in our volunteer department that, all you'd have to do is call our number and ask to speak to someone about volunteering. And they absolutely could help connect you to the right resources. Of course, all of our volunteers have to go through a volunteer training. that's that takes a commitment of a few hours or a few days to become sort of a certified volunteer, understanding what we're there to do and that kind of thing. But we're always in need of volunteers. And
It's great to know that those options are available.
yeah, we actually, COVID has been interesting because we sort of had to stop our volunteer services because we were just trying to limit the number of people going into different places.
Yeah.
We actually hosted our first volunteer training since the COVID outbreak yesterday and had great attendance. And it looks a little different, right? We're all in face masks and 6 feet apart and doing it a little bit different. But at the same time, our patients and families always have a need for volunteer support.
Yeah, and those little things that you mentioned, Aaron, can be huge. I mean, just that hour break from being a caregiver can make all the difference in the world.
Yeah, it can. One of the volunteers that was in the training yesterday, we had cared for her husband last year. And she said, I'm here because I had a volunteer that came in and spent 2 hours with me a week and gave me a break. And she said, I know this sounds crazy, but it saved my life.
Wow.
And I thought, wow, what a testament to just time, right? It's just time and presence.
Yeah.
And I think we know, I mean, just as humans, time and presence is so important. But I think when someone's going through this kind of thing, giving them a break or allowing them to sleep because they may not have slept all night is a gift that is really invaluable.
Yeah, absolutely. Any suggested resources for our listeners, websites or books beyond the Good Sam website, which we'll obviously include a link to in our show notes? Any other resources or reference tools out there that folks might benefit from?
Well, there's a lot of great resources out there. I always encourage people anymore. We become so enmeshed with Googling things and getting out there and doing, you can really put in anything. There's a lot of great resources out there across the nation for advanced care planning and end-of-life care and caregiver resources. There is a lot of resources out there, and I think caringinfo.org is a great place where you can go and they can connect you to a lot of different resources.
Very good. Any parting words of wisdom?
Yeah. I think that just the most important thing when we talk about advanced illness is just actually talking about it. Spending some time with your loved ones and the people that you care about, not only talking about those with advanced illness, but also talking about those that are going to be taking care of you. I work in this world, so at the same time, I think it's more relevant in my mind as far as the day-to-day, but I spend a lot of time talking to my wife and my children about what I want. And I can tell you that they are very, very attuned into sort of what I want and what my wishes are. And if I was to sort of start walking down the path of advanced illness, but just continuing to have those open conversations as you're faced with those things. So I think that that's just really the most important part is being honest, having the conversations, and really having those conversations now.
I think that's great advice and a great way to wrap up our conversation, Aaron. You've been more than generous with your time this afternoon, and I just appreciate so much all that you and your staff are doing for folks in the community who are finding themselves with advanced illness and at the end of their lives in some cases. So thank you sincerely for all that you do.
Yeah, thank you so much. And thanks for having us and encouraging people across the area to learn more about hospice and advanced illness care.
We're definitely happy to have you on the show, and I have no doubt that our listeners are going to find this conversation incredibly helpful. So thank you. Dissect and Connect is sponsored by Teen Connections, a leadership program through Planned Parenthood South Atlantic that empowers youth with the facts about sexual health and the skills to build stronger, healthier relationships. It's free, totally virtual, and you can earn $100 when you graduate as a Teen Connections peer educator in your community. Join a Teen Connections program from home today. For more information, be sure to check out the show notes from today's episode. We hope you've enjoyed this episode of the Dissect and Connect podcast. To learn more about Montgomery County Prevention Partners, our New River Valley Community Services, be sure to check us out on Facebook or visit nrvcs.org/podcast.